Hello everyone, I'm Dr. Komal Majumdar and my topic for the day is recent advances in implant aesthetics. Before I begin, I would like to say that I am a key opinion leader with Brilliant and BioHorizons. I have received remuneration from these implant systems at various platforms because I've spoken for them. This, however, is not a sponsored lecture and I'm not receiving any remuneration from any implant system. Some photographs of the patient's faces have been shown in this presentation. Prior written consent has been obtained for the same. All the cases shown in this presentation are my own. Some of the photographs have been cropped, but none of the photograph has been altered or photoshopped. I would like to thank Dr. Morris Salama and Dental XP for inviting me to this prestigious forum and speaking in front of you. And I come from the beautiful country of India. As you can see, this is the Taj Mahal, one of the 7 wonders of the world, which is in India. India is known for its rich colors and festivals. It is a place of hustle and bustle and hard-working people. It is also the home to the biggest film industry in the world. And of course, cricket. I can very proudly say that we are the top-ranked team in all 3 forms of the game. I'm a private practitioner and this is my clinic. This is my main operatory. We have a multi-chair setup and these are some of the units and maybe some more. We have a dedicated pedo section with a play area and a cafeteria. We also have a teaching center attached to our clinic where we conduct various CD programs. So coming to the topic for the day, and that is recent advances in implant aesthetics. Now we know, like aesthetics, beauty comes in various shapes and sizes. And so do implants in the aesthetic zone. Some are a bit long, some slightly short, some are a bit buccal, and some tend to be slightly palatal. Some have white ceramic in place of papilla, whereas some have these cool dark triangles. Some are a bit multicolored, whereas some have this funky metallic look. Or on second thoughts, we could get away from all this chaos and come up with results that look like this, or probably like this, or maybe like this, or this, and this. What we intend to do today is to show you my journey from this to this. Before I actually begin with talking about the advancement in implant aesthetics, let me show you one case wherein all of these principles have been followed. Meet my patient, Mr. Yogesh. Yogesh had a broken down tooth and he wanted a replacement for this particular tooth. If you can see, this is the occlusal view of the patient. If you can see the CBCT scan, you can see that the buccal bone is almost completely fused to the tooth root. In this case, we decided to go for socket shield technique or the partial extraction therapy technique, wherein I went ahead, protected the marginal gingiva and first got the tooth at the level of the bone crest. Once that was achieved, using a long shank carbide burr, I sectioned the tooth into 2 halves, the buccal and the palatal. Once the tooth was completely sectioned, I removed the palatal aspect using a luxator very gently. The tooth was removed using a long beak forceps, and now I proceed in making my shield much better. So I take my round burr and try to give a final finish to my shield. As you can see here, the shield is prepared. This is followed by verifying the position of the shield in relation to the bone crest. At this juncture, if you can see that the zeniths of the adjacent central incisor is not matching up with the tooth that we are going to replace. And we will address this issue once we come to the temporization aspect. Considering that there is adequate bone present in the palatal aspect, I start my pilot drilling in the palatal bone. You can see that the osteotomy is palatal to the socket and not in the socket. I continue my drilling and place my implant much palatal to the shield. So you can appreciate the distance between the shield and my implant. Once that is done, I verify the position in all the 3 dimensions. I take a RVG. This is followed by fabricating temporary in the clinic itself. Once the temporary has been fabricated, I go ahead and proceed with my dual zone grafting, and place my temporary on the implant. Now if you can appreciate, the temporary has been under contour to allow the soft tissue to creep on the tooth. After a period of 6 weeks, as you can see, I have achieved my gingival creep. Once I know that I have achieved the creep, I take out my temporary and modify this temporary as per the new gingival zenith. As you can see here, after a period of 12 to 15 weeks, you can appreciate the buccal architecture that has been preserved. You can see the beautiful final emergence that we have achieved. I go ahead, take out my temporary, attach it to the analog. I take this whole unit and place it inside the putty to record the emergence profile. You can see that the temps are removed once the putty hardens. After the putty hardens, I place my impression post on the analog. The space around it is created. I take little amount of light cured flowable resin and cure it. Once that is cured, I have a customized impression post that I can place in the patient's mouth and take my final impression. This is followed by the lab communication step for the technician. And here in this case, I used a prefabricated bio-HPP abutment with a medium emergence profile. My final Emax crown is fabricated. This is the final smile. And you can see the post-op RVG, post-op CBCT, showing that there is buccal bone, the shield and the implant. It can also show you the relationship of the buccal bone, the shield and the implant in this particular section. And you can see how beautifully the buccal architecture has been preserved. The tissues are seeming healthy, and this is the final smile of the patient. So now to understand the advanced topics in implant aesthetics, let's go back to the basics and understand the types of placement. Now, as per the ITA treatment protocol, there are 4 types of placement depending on when you remove the tooth and place the implant. So if you remove the tooth and place the implant immediately, it is called as immediate placement. If you wait for a period of 6 to 8 weeks and let the soft tissue healing happen, it is called as early placement with soft tissue healing. If you wait a little more, around about 12 to 16 weeks, and let bone healing happen to a certain extent, it is called as early placement with partial bone healing. And anything that you place after 6 months is called as delayed placement or conventional protocol. Let's understand the conventional protocol first. Now, in the conventional approach, the implant is placed after complete soft and hard tissue healing. The implant is countersunk and it is given complete closure. It is placed in a completely non-loaded environment. Now, why do we want to be conventional? Why do we want to go for a conventional placement? Because it allows complete soft tissue coverage. It is easier to get closure after the flap has been elevated, and finally there is lesser risk for any early loading on this particular implant. Now, why was this particular philosophy followed? The reason why this was followed is because of this study that says that no matter what you do, conventional or immediate, there is going to be some bone loss on the buccal plate. Or this study that shows that there is a loss of bundle bone periodontal ligament complex after extraction. So it becomes best to wait before you go ahead and place the implant. And what was the reason for this to happen? And the reason is the bundle bone. Now you have to understand that the bundle bone is a tooth related tissue and not a bone related tissue. It is embryologically related to the tooth, not to the bone. So the moment the tooth is removed, the bundle bone gets lost. Now I, for one, was a firm believer of the conventional approach, and I did a few cases with this approach. So let me show you one of the first cases that I've done with conventional approach, and that was a long time back, like 15 years ago. So meet my patient, Mr. Kashif. Now he had met with a roadside accident. I removed Kashif's teeth, the central and the lateral incisor, raising a flap. I placed 2 implants after a period of 3 months, gave the patient submerged healing, and once the implants healed and the patient came back for the prosthetic phase, you can see that the impression posts are attached. I go ahead, take my impression, and this is the final restoration. Not a very good aesthetic result, but this was really long time back. Now let me show you 2 other cases which are again the delayed approach. So meet my patient Kshitij. It's a young fellow who has lost his tooth, his lateral incisor, wants a replacement. When we see the pre-op of the patient, when we see the pre-op RVG and the CBCT of the patient, we realize that there is a buccal defect which is present. Now we go ahead, we raise the flap, we take an incision, we do our osteotomy with the stent. We ensure that we have a palatal access hole. We go ahead, as you can see that the implant is placed here and there is a defect, a buccal defect which is present. So this patient definitely requires a guided bone regeneration technique. We go ahead, we go to the donor side, that is the ramus area. We harvest some amount of bone. So as you can see, the first layer is the autogenous bone. This is followed by a layer of alloplast and a layer of beta TCP NHA for contour augmentation. This is followed by placing a membrane and stabilizing it. And this is the final result of the membrane that is stabilized. This is followed by tension-free closure. Now, once the implant was placed inside, I gave the patient a Maryland bridge. And once the implant integrated, I started my tissue molding phase to get the right contours. So I fabricated an temporary by placing an abutment and making attempts to contour the gums. Once I achieved the desired contours after a period of 8 weeks, I went ahead, took my impression, and this is the final Emax crown that has been given to this patient. As you can see, the post-op CBCT shows healthy bone levels. This is the pre-op and the post-op of the patient. And you can see the smile has been successfully restored despite the conventional placement. This is a 3-year follow-up of the patient. The tissues are healthy and the smile is still perfect. Let me show you another case of conventional approach where I place the implant after the extraction, after complete hard and soft tissue healing. So meet my patient Suman. This is a non-restorable premolar that I can see. As you can see, there was a draining sinus and the RVG shows that the presence of very minimal bone beyond the tooth apex. I go ahead and remove the tooth atraumatically without raising the flap. After I do my thorough degranulation, I realize that there is deficiency of the buccal plate. So I go ahead, raise my flap and start my degranulation procedure again. This is how the defect looks after degranulation. This is followed by decortication. I go ahead, do my flap advancement. This is followed by taking some amount of bone from the ramus again. I use my autogenous chip maker in the ramus area. Adjust my membrane. Make a composite graft of allograft and autogenous bone. Place the graft in the defect. Place my membrane and stabilize it. And I give a tension-free closure. After a period of 4 months, I come back, I evaluate and I make a minimal incision. I place my implant. You can see there is adequate bone present buccal to the implant. This is followed by minimal suturing and again a delayed protocol for the same implant. The patient comes back after a period of 3 months. I place my healing collar and now at this stage again, since it is the first premolar and it really falls in the aesthetic zone, I begin my soft tissue contouring using my provisionals. Once I achieve the desired emergence profile that I want, I go ahead, take my impression and fabricate a milled titanium abutment followed by a zirconia coping and a SCR prosthesis, that is screw cement retained prosthesis. And this is the final prosthesis. You can see the immediate post-op, beautiful aesthetics, the stable levels. You can see the post-op CBCT again showing healthy bone levels and the RVG. And this is the 1-year follow-up of the same patient. So you saw how I proceeded with my case in the beginning. Now, when I talk about the implant in the aesthetic zone, there has been a paradigm shift in the way we treat our cases in the anterior zone. There has been a paradigm shift in terms of philosophy. In this, we will talk about immediate placements, we'll talk about placement in the infected site, we'll talk about immediate provisionalization, we'll talk about one abutment, one time concept, and we will talk about the relevance of palatal placement in the anterior zone. There has been a paradigm shift in biomaterials. The materials that we use now in terms of implants have better implant surfaces, in terms of osseodensification using densa burrs and bio-HPP and zirconia. There has been a paradigm shift in terms of techniques. In this we will talk about atraumatic extraction with no flap, we'll talk about the dual zone grafting, and we'll talk about socket shield and partial extraction therapies. So let's take each one of these paradigm shifts and let's discuss them as the recent advances in implant aesthetics. So beginning with the philosophy. In this I will talk about immediate placement and the concept of smallest possible and widest necessary implant. Now, one of the biggest reasons why conventional implantology or conventional placement was followed because the dimensional changes after the immediate implant placement in the extraction socket was very high, and you can see with these studies that the amount of dimensional change is almost going up to 6 mm. But when we closely look at these studies, we realize that most of these studies were done with flap elevation. And if you see studies like these, there is one, for example, done by Grunder, that shows that the dimensional changes after the extraction is very, very minimal. And the reason why this was possible, because all these studies were done wherein the flap was not elevated. So the key to immediate placements, especially in the anterior zone, is to not raise the flap. Now the question is, do we really need to give immediate implants in the aesthetic zone? And the answer is yes, definitely a yes. Because from patient's point of view, it is a single procedure. The patient has to take anesthesia once, remove the tooth, place an implant and have a provisional immediately after the surgery. Because it's a single procedure, it is less traumatic for the patient, both in terms of surgery and psychologically. And because of this, there is better patient acceptance. But from the aesthetic point of view, it makes much more sense to give immediate implants. And the reason is, once you give an immediate implant and make the provisional immediately, you make sure that you prevent the collapse of the papilla. It does not stop, but definitely minimizes the soft tissue recession. And because there is such great harmony between pink and the white, the final aesthetic results are definitely better. Now the question is, do all cases go for immediate implant placement? And the answer is no. You've got to be very, very specific about case selection when you want to go for immediate implant placement in the aesthetic zone. I go for immediate placement when I see a grossly decayed, non-restorable, asymptomatic tooth, or there has been traumatic loss of tooth with minimal bone loss, or I see a tooth with no sign of any active infection, and I see that there is thick, stable and keratinized gingiva not only of the tooth that we are replacing but also of the adjacent tooth. If I see that I have an extraction socket that is favorable for my implant placement and I have adequate bone present, apical to the extraction socket for my initial primary stability. When do I not go for immediate implants? I do not go for immediate implants when I see that there is a major defect in terms of both hard tissue and soft tissue. So I need to correct that first and then go ahead and do my implant placement. Now the question is, do immediate implants really work? And the answer is yes. If you see certain studies, like the one that is done by Chen, this is a systematic review that shows that there is almost 95% survival rate if you see a 3-year follow-up. Or if you compare two studies showing the survival rate, you can see that there is no significant difference between the conventional placement and immediate implants. So having said that, let me demonstrate a case to you of immediate implant placement. Meet my patient, Mr. Kunal. Now you can see that Kunal has a broken down upper left central incisor. We go ahead and remove the tooth atraumatically using luxators and periodontals. And while I am removing the tooth or while I am extracting the tooth, I ensure that the buccal plate is adequately supported. This is how an extraction socket should look like after the extraction. I go ahead, do my degranulation. This is followed by placement of the implant through the stent for ideal placement. And you can see that I am verifying my placement with the pilot drill, which is much palatal. If you can see this slide, you can appreciate that the extraction socket is much buccal and the osteotomy that has been done palatal to the socket. Now, I also spoke to you about the concept of widest necessary smallest possible implant. Now, this is done to ensure that the implant is not touching the buccal plate, but there is a jumping distance which is maintained between the buccal plate and the implant. So you can see here that I have placed my implant in ideal position, keeping a distance from the buccal plate, keeping adequate distance from the adjacent teeth, and ensuring that it is 3 to 4 millimeter apical to the free gingival margin. I go ahead and fabricate my provisional. After I fabricate my provisional, I go ahead with my dual zone grafting. So I go ahead, place my implant there, place the healing collar over it, and graft not only in the hard tissue zone but all the way to the free gingival margin, and that is the soft tissue zone, and hence achieve a dual zone grafting. We will talk about this concept again in the future further slides. So here I place my provisional. This provisional is acting as my prosthetic socket seal, which is retaining my clot and retaining my graft also at the same time. Now, unfortunately, once I gave the patient the provisional, after a few months, the patient met with an accident and broke his adjacent teeth, his adjacent crown. Not only did he break his adjacent teeth, but also the provisional that I had given to him. Thankfully, the abutment and the implant were intact. So I went ahead, did my final preps for the adjacent teeth. But you can see here that the emergence profile is still intact, the papilla are still intact. After the impression procedure was finished, the abutment was placed, and this was the final result for the same patient. Now, implant in the aesthetic zone is not only about white. White is what your technician can give you, and or how talented your technician is. Pink aesthetics is the most important aesthetics. Now, there is a pink aesthetic score that has been given by Rudolf Hauser, which gives 7 criteria, and each criteria is given 2 points. So if you fulfill that particular criteria, you get 2 points. So if I see the pink aesthetic score for Kunal, I would think that I have got 13 on 14, which is a pretty decent score. Now coming to the next philosophy, and that is placement in the infected sites. Now, what is an infected site? An infected site is any site that exhibits signs and symptoms of pain, periapical infection, radiolucency, suppuration, or a combination of these. Now, historically, placement of implant in the infected site has been contraindicated, like this study by Schrock. And also there are other studies besides that show that implant in the infected site should be avoided. And the reason being, infection can hinder in the process of osseointegration. Also, there are studies to show that there is greater chance of implant loss once you place an implant in the infected site, and it becomes a predictive marker for future peri-implant disease. But there are other studies like these that show that implants can be placed in the infected site. Like this study, which is done by Crespi, which shows that in a 2-year follow-up, the implant in the infected site shows predictable outcome. Or this study says that implant in the infected site will show a high survival rate despite the presence of infection. Or as a matter of fact, this study that shows that it's a valid operative technique if you follow certain protocols or certain pre and post-operative care. Now there are certain guidelines which you can follow when you are treating an implant in the infected site. The first and the foremost being that it requires thorough degranulation and disinfection. It has to be done under high magnification and illumination. Now certain studies show that you need to use antibiotics before, systemic antibiotics, and also you need to irrigate the infected site with 600 mg injection clindamycin followed by chlorhexidine gluconate 0.12%. You will have to use maybe a little wider and longer implant for higher primary stability. But there are other studies like these that show that you really don't require to irrigate the site with any antibiotic solution. So let me demonstrate a case to you where I placed my implant in an infected site. Meet my patient Seema. You can see that there is a broken down tooth here and she has a huge periapical radiolucency which is attached to the tooth. Now thankfully we have certain amount of bone present apical to the radiolucent area. Now, one of the most important criteria of immediate implant placement is getting high primary stability. So in this case, I know that I will achieve some amount of primary stability because of the presence of bone beyond my infected area. So I go ahead, remove the tooth atraumatically using luxators and periodomes. You can see the amount of granulation tissue which is present. I go ahead and degranulate that area. Now, and this is how the socket looks after thorough degranulation. Once the degranulation is done, using my stent, like the other cases that I showed you, I place my implant in the ideal position, ensuring adequate distance between the implant and the buccal plate, adequate distance between the adjacent teeth, and 3 to 4 millimeters submergence of the implant. So I am maintaining my jumping distance here. I go ahead, do my dual zone grafting again in this patient. Now, since I did not achieve a very high primary stability, I could not give the patient a provisional, but I could definitely customize my healing collar and place it. Thankfully, this patient required a crown on the adjacent tooth, so I could give a Maryland prosthesis to the patient for the temporization. After the healing, this is the immediate RBG of the patient. In the restorative phase, you can see I have got a beautiful emergence profile, the tissues are healthy, and this is the final restoration of the patient. You can see that there is no infection, the tissues are absolutely healthy, and this is a 4-year follow-up of the same patient. So you can see that if you follow the protocols of placement of implant in the infected site, you can get desirable results. So now coming to the next philosophy, and that is immediate provisionals. Now, why do we want to give immediate provisionals to our patient? Apart from the fact that any patient would want a front tooth immediately before stepping out of the office, it is not the implant or it is not the abutment that supports the soft tissue. It is the provisional restoration that you give the patient immediately after implant placement that ensures that the soft tissue is supported, that the papilla does not collapse. It is this restoration that will determine your final emergence profile. So to explain you the relevance of provisionals in an immediate implant placement, let me show you a case. Meet my patient Chitra. Now Chitra had a badly broken down tooth. As you can see here, this is the occlusal view. Now the patient we had different options. Now we did not opt for crown lengthening procedure to make a post and core and a crown, because if we would have done this kind of procedure, it would lead to the mismatch of the zeniths. The patient refused to undergo any orthodontic extrusion to ensure that is a good ferrule which could give a good crown to the patient, and a traditional bridge was definitely not acceptable to the patient. So we went ahead and did our immediate placement and provisionalization for the same patient. After doing thorough preoperative analysis, wherein we determined the gingival prototype, we determine the shape of the teeth, we see the amount of bone present beyond the extraction socket, we realize that this is possibly a great case for immediate placement. So we go ahead, remove the tooth atraumatically using periodomes and using long beam forceps. Placement of the implant in the ideal position. You can see in all the 3 dimensions. I go beyond the socket to achieve high primary stability. Since we achieve high primary stability, I fabricate my provisional. Now this provisional was fabricated in the clinic itself. So I went ahead, I took an open tray impression of the implant and poured the cast in the clinic. Once the cast was poured, I fabricated my provisional on the cast and verified it intraorally. Once that was done, I fabricated a screw retained provisional with a palatal access hole. The contour of this provisional depends on where your implant placement has been done. If your implant has been placed adequately palatal, the cervical contour of the provisional can be convex. If your implant placement has been either central or buccally, you need to have a concave sort of a provisional. So here we have the same day post-op. Obviously it is non-functional, not loaded immediately. Now you can see here the patient comes back to us after a period of 12 weeks, and you can appreciate the beautiful emergence that we have achieved, and that has been possible only because of the immediate provisional that we gave the patient that maintained the soft tissues, that maintained the papilla. This provisional, which has given this beautiful contour, is of no use if we cannot transfer this information from the patient's mouth to the technician. So we customize our impression post and fabricate a customized impression post for the patient. We place it. You can see how beautifully the customized impression post is also supporting the soft tissues while taking the impression of the fixture. You can see here this is the final impression, and then we fabricate a screw retained final prosthesis for the patient. You can see the palatal access hole, and this is the final smile of the patient. The pink aesthetic score for this patient again would be something like 13 or 14, which is again not such a bad score. And this is the 5-year follow-up of the patient. You can appreciate how beautifully still the tissues are holding up. Of course, there has been some amount of collapse, and we will address this problem in the further philosophies that we now have incorporated in our practice. So coming to the next philosophy, and that is the palatal placement of the implant. Now, the current factors that influence the placement of the implant palatal to the socket is the gingival biotype, the amount of facial bone thickness and the height, the amount of bone beyond the socket, and the jumping distance. So these are the current guidelines that we follow, and the current guideline says that once you start your osteotomy, you need to start it in the palatal wall. Once you get a purchase point, you straighten your drill. Like you can see in this slide, I have started my placement in the palatal socket. I have started my placement in the palatal wall of the socket and then straightened my drill to get a palatal access hole. Now you can appreciate here that the osteotomy that I have done and the socket are two different osteotomies. Once I achieve that, I place my implant, and you can see that how palatal the implant has been placed. Now you have to understand that it is not possible all the times to get this palatal placement of your implant, and that is because it is not just the current factors that are responsible for the palatal placement, but there are two most important factors, and that is the tooth root position and the amount of palatal bone that is present in that area. So this is the most recent classification that has been given by Dr. Harvey Gluckman that gives us a radiographic classification based on the amount of bone present palatally and the inclination of the tooth. So we can see that there are different classes of teeth and the type of prosthesis, and where you begin your osteotomy depends upon this classification. So if you see class 1, in class 1 the tooth is positioned right in the middle where there is adequate bone present both facially and palatally. Once you have this kind of a classification of your tooth, you need to start your osteotomy right at the apex of the tooth. This is an ideal case to achieve cement retained prosthesis. If you wish to go for a screw retained prosthesis, you need to slightly straighten your drill. The primary stability is achieved from the apex. In a class 2 situation, there are two types. There could be a class 2A and a class 2B. In class 2A, there is adequate bone which is present on the crest, on the buccal aspect, but as we proceed more apically, the amount of bone reduces considerably. But there is adequate bone which is present on the palatal aspect. Class 2B shows exactly like class 2A, but with lesser bone at the crest. Now these type of teeth in the class 2A or 2B are ideal for palatal placement of the implant because there is adequate bone which is present palatally. Of course, if you have a high aesthetic risk case, do not go for immediate implant. Even in such cases, go for a conventional or a delayed approach. The primary stability in this case is achieved mainly from the palatal bone. Class 3 is a situation where the tooth is completely proclined and there is adequate bone present in the palatal aspect. In high aesthetic risk cases, again, do not attempt to go for immediate placement. The primary stability here comes from the palatal part, and this is a perfect case to achieve a screw retained prosthesis. Class 4 is a situation, as you can see, that there is ample of bone which is present on the palatal aspect, and you can go ahead and start your osteotomy in the palatal side of the socket and achieve primary stability from the palatal bone. Merely 7.3% of the teeth fall into this category. Class 5 is a situation in which there is inadequate bone present both buccally and palatally, and even beyond the socket you cannot achieve high primary stability. Now class 5 is a situation where you have to completely avoid immediate placement and go for a delayed approach. I made a mistake going for immediate placement in a case which was class 5, and let me demonstrate to you what can really go wrong if you attempt an immediate placement when there is lack of palatal bone, when there is lack of buccal bone. So meet my patient, Mrs. Shama, in which she has a broken down lateral incisor. She had 2 crowns, one on the canine and one on the lateral incisor. The lateral incisor fractured. You can see this is the occlusal view. So in this case, we decided to go for socket shield. Now if I show you the CBCT of this patient, you will realize that there is no bone from which I can get primary stability both buccally and palatally. The buccal bone is completely fused to the tooth root. So I decided to go for socket shield technique. I section the tooth mesiodistally and I remove the palatal part using my luxators atraumatically. I go ahead and prepare my shield to the crest of the bone. Now once that is achieved, I place my implant. I achieve high primary stability, and you can see that there is still adequate distance between my shield and the implant. I go ahead, since I get high primary stability, I use my bio-HPP abutment. I go for one abutment, one time concept. I take the patient's own crown and modify the abutment and use the same crown to fabricate the provisional for this patient. So as you can see here, I'm flushing the margins using the same crown, and this is the temporary, which is also the final prosthesis for the patient. I place it down. I do my dual zone grafting. Before that, you can see here I've achieved the dual zone grafting. This is the same day post-op of the patient. Now this is how she walked out of my practice, but after a few months, that is after a period of at least 4 months, the patient reports back to me saying that she is having some minor swelling. When I look at the clinical picture, I see that there is a minor swelling. I track down the fistula tract with using a GP point, and I realize that it is the same implant which is giving me the problem. I try to give the patient antibiotics, but it really does not solve the problem. So I go ahead, I raise an aesthetic buccal flap, and I can see the amount of thread exposure that is present there. I clean that area up, use my graft material, use my membrane and stabilize it, and give a suture. And this is how the patient is in the healing phase. As of now, the patient is asymptomatic, but I am keeping my fingers crossed when it comes to this patient, because I really don't know how much this tooth is going to survive or this implant is going to survive. So to summarize, 3D implant placement cannot be generalized. CBCT evaluation is absolutely required for us to say that implant has to be placed palatal to the socket and not in the socket. Now coming to our next paradigm shifts, and that is the philosophy of one abutment, one time. I just showed you one case where I did one abutment, one time, but why are we wanting to go ahead with this philosophy? Now there are studies to show that subsequent disconnection and reconnection of the abutment components may compromise the mucosal barrier. It will lead to greater bone remodeling and lesser stability of the soft tissues. So it has been advocated that the connection of the definitive abutment should be done at the time of the surgery. That means you place the abutment once and do not change the abutment again ever. So this is the concept of one abutment, one time. And the previous case that I showed was the concept of one abutment, one time. So coming to the next paradigm shift and the use of biomaterial, and that is osteodensification using DENSA burrs. Now, one of the factors given by Albertson for reliable osseointegration is improved surgical technique, and DENSA burrs is one of the techniques which help us improve this surgical technique. DENSA burrs ensures that we get high primary stability and we use the property of plasticity of bone to our advantage. DENSA burrs can be used in any side, not just anterior but also posterior. So let me show you a case where the DENSA burrs were used to our advantage. So as you can see that this is a completely non-restorable tooth. I section the tooth out and I extract the teeth. You can see the extraction socket. I go ahead, do my degranulation and disinfection, and now using the DENSA burr in the anti-rotational motion, I go ahead and densify the bone. You can appreciate the densification that I have achieved of the bone, and I achieve very high primary stability. I place my implant in the correct 3-dimensional position. Because I achieve good primary stability, I customize my healing collar, and you can see here this is the 7-day healing. Once the implant integrates and I remove my customized healing collar, you can appreciate the beautiful emergence that I have achieved in this case. This is followed by impression making and the metal trial, and this is the final prosthesis. You can see the post-prosthesis RVG, which shows stable bone level on this side. And this is the final result using osteodensification with densabos. Now coming to the next topic, and that is one of the advancement in anterior zone, is the use of a biomaterial called as the bio-HPP. Now bio-HPP is a material that can be used as a temporary or as a permanent abutment. It has got good mechanical and chemical properties. It is highly aesthetic, and the most important is that its modulus of elasticity is almost similar to the cancellous bone, so the amount of forces that are generated and are transferred to the implant are much lesser than any other material that is available as an abutment material. So let me demonstrate a case to you in which I went ahead and I did one abutment one time using a bio-HPP abutment. So you can see here, this is one of my patients, meet Mr. Om. You can see that the patient has a central incisor, but if you see the CBCT and the RVG of the patient, you realize that there is a fracture line in that particular tooth. So once I take out the crown, I realize that it is a badly broken down tooth. We go ahead and decide to do a socket shield technique in this patient. We realize that there is adequate bone present palatally for our palatal placement. I go ahead, I section the tooth using a long shank carbide burr. You can see that I have achieved the sectioning buccally and palatally. I remove the palatal part atraumatically using my luxators. I protect my marginal gingiva and make the shield at the level of the crest of the bone. Once that is achieved, and my shield is ready, I go ahead with my palatal placement of the implant. Once the implant is placed in the correct 3-dimensional position, I place my bio-HPP abutment intraorally. I go ahead and mill the abutment, and using the patient's own crown, I fabricate a temporary over the bio-HPP abutment. You can see here, this is the same day post-op of the patient. The patient walks out, you can see the 8 weeks post-op, the tissues are healthy, and this is the final smile of the patient. This is the final post-op of the patient. Coming to now the next paradigm shift, and that is the techniques. The first technique that I want to talk about is atraumatic extraction with no flap. Now I showed you multiple cases of the teeth in the anterior zone, and most of the cases were done without raising the flap. Now why is that so? That is because studies show that raising the flap can lead to greater bone loss and soft tissue recession. And why does this happen? To understand this, you need to understand the blood supply of the buccal bone. Now the buccal bone has 3 sources of blood supply. One is the periodontal ligament, which is lost the moment you remove the tooth. The second is the bone marrow. Now this bone marrow is relatively very small to support or to give any kind of nourishment to the buccal bone. And the third source of nourishment for the buccal bone is the flap. So if you raise the flap, you are depriving the buccal bone from the only source of blood supply. So to achieve this, to achieve the atraumatic extraction, you need to not raise the flap. And how is atraumatic extraction performed? Of course, there are lots and lots of techniques. One of the techniques that I tend to follow is the use of periotomes and luxators. The points to remember in using periotomes and luxators is that you have to remember that they are not elevators, and they have to be used extremely gently. They have to be used only in the interproximal sites and not in the buccal site ever. The key to atraumatic extraction is patience. If you try to hurry up the procedure, it will lead to either breakage of the tooth or breakage of the periotome. Coming to the next part, and that is the dual zone grafting. Now, what is dual zone grafting? Dual zone grafting basically is, like I showed you in the previous cases, is grafting in 2 zones, that is the hard tissue zone and the soft tissue zone. Now, why are we trying to do this? Now, there was a study that was done by Khan which says that in an immediate implant placement, for better soft tissue results, it is better to go ahead and do a connective tissue grafting. Now, there was a study that was done by Chu et al. Which shows that a similar soft tissue response can be achieved by doing the technique of dual zone grafting, which improves the soft tissue profile and potentially enhances the thickness of the peri-implant soft tissues. So if you compare doing a CT graft or doing a dual zone grafting, this technique seems very simple and easy to perform. So this is how it is done. Once you place your implant, you place the healing collar and a low profile healing collar, not a very wide healing collar, so that there is adequate space for you to place the graft material. You place the graft material, gently push it through with your periodontal probe and graft the hard tissue zone and come all the way to the soft tissue to achieve the dual zone grafting, as you can see here. So coming to our next paradigm shift, and that is in biomaterials, and the first one is better implant surfaces. Now, one of the prime reasons why immediate loading was not advocated was because of the machined or the smooth implant surfaces that were available. Now, these smooth surfaces of the implants were not able to retain the fibrin clot that would help to migrate the osteoblast on the implant surfaces and lead to contact osteogenesis. These days, because of better implant surfaces, we have enhanced osseointegration, leading to faster implant placement and faster loading of the implants. Now coming to the last paradigm shift and in the technique, and that is socket shield or partial extraction therapies. And I think this is one of the most important paradigm shifts that we have seen in the anterior implant placement. Now, what is socket shield technique? Socket shield technique basically is a type of immediate tooth extraction and implant placement wherein we retain the buccal part of the root. Now, why are we doing this? We are doing this because there are a lot of studies that show that recession of 1 millimeter of buccal gingiva is expected following immediate implant placements, and it is worse in thinner biotypes. Or this study that shows that there is an overall reduction in the horizontal dimensions following tooth extraction, and the resorption is much more prevalent on the buccal aspect than the lingual part. Now, why does this happen? Now, as I already mentioned to you, that the problem is the bundle bone. Now, the bundle bone is a tooth-related tissue and not embryologically related to bone. So, the moment you remove the tooth, the bundle bone gets resorbed. The principle of socket shield is that this buccal plate of the root is retained, and we cheat the body into believing that the tooth is not being extracted. If the buccal part of the root is not extracted, that retains the bundle bone, leading to greater hard and soft tissue stability. So one may ask, why not socket grafting or guided bone regeneration? Well, to begin with, for doing these techniques, you require greater biomaterials, which are expensive for the patient. You require extensive surgeries. Now, what we have to appreciate is that the patient is coming to us for teeth and not for extensive surgeries. So let me demonstrate to you a case wherein we went ahead and did our implant placement with a delayed protocol. So if you can see me, my patient Ravikant. The patient had undergone an extraction a few months back, and you can see here that this is the pre-op picture. We go ahead and give an incision, a papilla preservation incision. I go ahead and raise the flap. You can see that there is a huge defect which is present here. I use my stent to place my implant in the correct prosthetic position. I place my implant. Once the implant is placed, I know that there is a defect here and it needs to be taken care of by guided bone regeneration. I do my decortication. I go ahead and graft the area using autogenous bone and some amount of biomaterials. I place my membrane and stabilize it further using membrane stabilizing suture. For better soft tissue healing, I also use PRF and get a closure with my sutures. The patient is given a submerged healing. Once the patient comes back, I give the patient a final prosthesis using a titanium abutment. Since the patient has got a thick biotype, even with a titanium abutment, I can achieve adequate enough aesthetic results for this patient. And you can see the patient has a considerably low lip line, and this is the final smile of my patient. Now you can see the 3-year follow-up of this patient, and you can see that the soft tissues are holding up pretty much fine. But if you look at this picture, you can see the amount of collapse that has been present after a period of some years. Now the question is, well, if you don't want to go for delayed protocol, why just not go for a complete extraction and immediate implant placement? The answer is that despite doing an immediate placement, some collapse is always seen. And that is because both guided bone regeneration and your immediate placements fail to fully compensate the compromised blood supply. That is the prime reason for the loss of bundle bone. Socket shield is more of a preventive technique than a corrective technique to make sure that this bone is preserved. The question is, does socket shield work? Now you have to understand that preservation of the root to preserve the alveolus is not something which is very new. This concept has been present since the 1970s, and like this study shows that the preservation of the root was a part to preserve the alveolus, or these studies that show that retention of the root was purposely done for the preservation of the alveolus. So socket shield essentially can be called as a modification of the technique that was done in the 1970s. And this study done by Herzler says that retention of the buccal aspect of the root during implant placement does not appear to interfere with the integration of the implant. In fact, it may be beneficial in preserving the buccal plate. Of course, there are a lot of other studies like this done by Khan, which says that preserving the buccal plate of the root seems to increase the soft tissue aesthetics in the area by maintaining the mucosal zenith at a more coronal position. And there are numerous case reports and case studies that have been done that are pro this technique. To essentially summarize the whole of socket shield technique, I would say that it is the most contemporary technique of implant placement in the aesthetic zone. Preservation of the periodontal ligament and bundle bone complex, use of minimum armamentarium and biomaterials, and minimum trauma to the patient are some of the pros of this technique. A learning curve, technical difficulties, and lack of enough evidence in literature are some of the cons of this particular technique. However, this technique challenges the conventional extract and augment approach. Proper case selection and treatment planning are the cornerstones of this particular technique. But you have to understand that socket shield cannot be performed in each and every case. Socket shield has to be done in cases where you see healthy and stable buccal root, when the buccal plate is completely fused to the root and there is a presence of healthy gingival sulcus. Do not attempt to go for socket shield when you see mobile roots or deep infected pockets or there is a presence of active infection. So let me show the last case for this presentation of a socket shield technique, where I show you the protocols that I have followed for this particular technique. So meet my patient Sarika. As you can see, she has got a badly broken down tooth. She has got adjacent decay. This is the pre-op X-ray of the patient. This is typically a class 2B classification. I have adequate bone which is present on the palatal aspect. This is the occlusal view. You can see that the buccal architecture is preserved naturally because of the presence of the root. I take care of the adjacent fillings and I'm ready for the surgery. I go ahead and start my steps in socket shield. The first step that I do is protect my marginal gingiva. Here I have used a simple periosteal elevator. There are instruments available to protect the marginal gingiva. I retract the marginal gingiva and I take the tooth to the level of the crest of the bone. Once that is done, I take my long shank carbide burr and section the tooth into buccal and palatal aspect so that I cut it mesiodistally. Once the complete sectioning happens in the mesiodistal direction, I remove the palatal aspect of the tooth using a perio tool, atraumatically. Once the tooth is out, I start to prepare my shield. Now the preparation of the shield has to be done with a long shank round burr. The thickness of this shield has to be 1.5 to 2 millimeters. Any thicker than this will lead to lesser place for the implant. Any thinner than this will lead to the flexure of the shield. So once that is achieved, I now have my shield ready. As you can see, and as we had seen in the CBCT, that there is more than adequate bone present for me to place in the palatal direction. So I start my osteotomy in the palatal wall. I place my implant in the palatal bone, keeping adequate distance between the shield and the implant. one of the prime prerequisites is to have a space between the shield and the implant so that we could go ahead and do the grafting in that area. I achieve high primary stability, I place my abutment, and using Protem 4 and a key, I go ahead and fabricate my provisional. The patient walks out of the clinic looking like this. When the patient comes back after a period of 12 weeks, you can appreciate the beautiful emergence profile after 3 months. You can see the papilla has been preserved. You see the zenith is maintained. But most importantly, what you see is that the buccal architecture is still preserved. Now, obviously, this is just about in the first 3 months. This case we will see after a period of 3 years. So you can see I go ahead, take my customized impression technique, place my zirconia abutment, and fabricate a cement retained crown for this patient. So this is the final post-op, and now when you see the 3-year follow-up of this case, you can appreciate how beautifully the buccal architecture has been preserved. Compare this to the loss of buccal architecture in a GBR case and an immediate implant case. So you can see here there is no collapse. You can see the 3-year post-op CBCT of the patient showing healthy tissues. And this is the final result. Even after 3 years, everything is looking absolutely fine. So coming to the take-home points. The rule number 1 in the implant in the aesthetic zone is proper case selection. Most of the failures happen because of improper treatment planning and case selection. Precise 3-dimensional placement is much more relevant than costly zirconia abutments and aesthetic abutments. A good provisional is the key determining factor in contouring the gums, much more than the implant or the abutment used. The skill of the operator and technique matter much more than costly implant systems, stents, and PRF machines. The work you are doing is actually a signature that you're leaving in your patient's mouth. And contrary to what people may tell you, it is a race. And the dentist who does the maximum implant cases in a given month, who delivers the more beautiful smile and has the happier patients, wins. So, go for it. Thank you very much.